feelings of hopelessness, lack of purpose. They become reckless, giving away possessions, organising affairs like, someone's organising a will, for example, or talking about death and suicide. So there's sort of situations where you probably consider an escalating situation, at least in the remit of this course and the program. These aren't exhaustive, by the way, and obviously each individual is different, but these are sort of things that the course we've touched on. If someone's at risk, obviously in immediate risk, then there are, and we've sort of gone through some credible organisations that can be signposted. Now, obviously, if they're in immediate risk, then it involves emergency services. If they have a support plan, some people do, you might know someone that has, if you work with someone with a support plan, then there might be a number on the plan. And there's charity helplines, like Samaritans as well. But the consensus there is that not leaving someone alone until help arrives, if you're in a situation like that at work or in general, then just hanging around until the appropriate help arrives in the situation. So that's a crisis. That can include, talked about suicidal thoughts or behaviour, extreme panic attack, extreme anxiety, psychotic behaviour, irrational and out of control behaviours. Okay. So there is sources of information. NHS website's got information on there. Anyone ever access the NHS website? Okay, there's a lot of information on there. Protocols, details. Samaritans, we're all aware of Samaritans as well. They're 24 hours around the clock, people can phone Samaritans as well. There are other organisations and charities that have been set up that are credible. We'll sort of touch on those on the course too. So Samaritans, I believe, are one of the oldest ones, or have been around for a while. They can help with support. People can speak to Samaritans. That's a useful one. Mind, anyone ever come across Mind? Yeah. Okay, so it's just signposting people to situations, and obviously in certain situations where appropriate, one could offer to attend an appointment with somebody. Everyday tasks as well, and just providing support, encouragement, and empathy, and a listening ear in certain situations. Now, organisations offering support, GPs, make initial GP makes the initial assessment, discusses treatment options, and signposts other services. So the reality is, in many cases, if someone is potentially suffering from mental health, then the GP would be a good place for them to go to talk to. And we talked about it yesterday. Early intervention is really, really important in a number of conditions, and in depression, especially with the evidence around early intervention being really important. But the GP can make the assessment and obviously decide what treatment protocol or whatever he's doing, or potentially the person might need medication, and that's obviously the role of the GP. Community mental health teams, anyone come across that? CMHT. So they support people with severe and enduring mental health problems that remain living independently within the community. You've got crisis teams, and they're available 24 hours a day, usually available by telephone and sometimes found within A&E departments. The priority is to keep the person safe and to manage their symptoms. Crisis team. Okay, so we'll sort of go through some details where crisis teams are concerned, but obviously in certain situations, like we talked about earlier, A&E and getting the person the appropriate help, which emergency services if the person's at risk for themselves, and so on and so forth. Beyond that, you've got charitable organisations, student services, and workplace support as well that can potentially support. Let's look at some statistics now. And this is from the Office of National Statistics 2017. among the persons, the highest rate, what's gone up now is amongst the rates that have increased is the 45 to 49-year-old has gone up. The suicide rate for that age group has gone up over the last few years, and this was released on the Office of National Statistics 2017. In America, because a lot of the body of research is, a lot of it's Western based, we'll sort of look at some stats in the UK and America. In America, there's 50,000 estimated suicides every year. And a high proportion of those, according to the AFSP, are 51% gun deaths. Okay. The National Office of Statistics in the UK, there was 5,821 suicides in the UK in 2017. The standardised rate of 10.1 deaths per 100,000 population. The highest age-specific suicide rate was 24.8 deaths per 100,000 among males between 45 and 49. The females, the age group was 50 to 54, the highest ratio, 6.8 deaths. So there's a few stats, and you can sort of get these stats on the National Statistics website. In 2017, there were 5,821 suicides recorded in Great Britain. Of these, approximately 75% were male and 25% female, according to the research statistics. Suicide also is the most common cause of death between men aged 20 and 49, and that's according to the research as well. In the United Kingdom, the proportion of suicide method is hanging. That's the highest method for the research as well. From an EU perspective, actually, as it happens, in the United Kingdom we have a considerably lower than some European countries. Generally speaking, the highest suicide ratios in Europe are in Eastern Europe and Northern Europe. Okay, they're significantly higher suicide rates in the UK, Western Europe and Southern Europe. Obviously one suicide is one too many, but we have a lower proportion in that respect compared to Eastern and Northern Europe, as the stats say. And ironically, since 1861 when records began, the ratio's not much different. You don't find that surprising that when they first released the records, and still pretty much.
You think it would be higher now
Yeah.
because of the pressures
Yeah.
that people are under?
Yeah, and different pressure. Yeah, absolutely. And that's sort of it's an interesting point you made there, because we're going to sort of look at risk factors, or non-risk factors, because it's obviously difficult to come up with a risk factor. There's so many correlations, involved, and mental health being one. Absolutely. Which is why it's really important if someone is suffering from mental health to get treatment as early as possible, because it carries comorbidity. See, in my infinite wisdom, and my suspicion is that these probably don't factor in comorbidity. So, for example, let's say someone they might not commit suicide in the sense where they are firearm or hanging, but they might drink themselves. So it's oblivion. They might sort of, in a cluster of rage, drive the car, often in back. So it might be an indirect way. It might be they overdose, so they, from a drug point of view. So it might not be directly a direct incidence where I don't know. Something that would have to be clarified. The National Statistics. I need further clarification, but I'm not entirely sure that they take that into consideration, the number of people who just give up, so to speak.
Did they look at things like if people have left a note, or if there's been any
Yeah.
signs, don't they? Because otherwise it's recorded as death by misadventure, isn't it?
Yes, well, I believe so, to a point, but equally there's comorbidity where, for example, people indirectly they might put themselves in danger. They wouldn't necessarily put themselves in normally. And that's one thing that we need to consider. So we do need awareness. We do need to really keep banging the drum and get more because, you know, whilst I think it's really highly commendable that we've had celebrities come out and talk about their mental health problems, I think it's good to a point because it opens up dialogue. It helps people to reduce the stigma as well. And, you know, equally, there has been some people, celebrities over the years, who have committed suicide. And, you know, the likes of Cornell, Soundgarden, Linkin Park, and Robin Williams, so there's people. So obviously there's a number of correlations and pathways to someone not feeling so good. It's not just a question of, like, you know, financial, socioeconomic status, it's other things that are at play too. And equally, I think it's really important that people do come forward and speak. But as I mentioned yesterday, and as I stand by what I said yesterday, and a discussion I had one time with a teaching fellow on a module I was covering on a course, and I think it might have been taken the wrong way. What I was saying is that whilst I think it's really good that some people come out and talk about it, and it's really great that you've got the likes, I think it was Prince Harry talking about his mental health, yeah, okay, and the likes of the boxer, Tyson Fury, and other people obviously who've come out. I think it's good for them to talk about it. I think it raises awareness, but equally I stand by what I said, that I think that, okay, there's a general person on the street who is trying to hold down a job, working hard, and I think that we still have a lot of stigma around that. Who's probably going to be afraid to speak to the boss or anyone in fear they might lose a job, in fear they might not make a mortgage payment, in fear of what people will think. And whilst I think it's really highly commendable that, you know, people do speak, the general person on, you know, the street, the general person doesn't have the luxury to get the support that some of these people can afford to get.
In some respects, you can look at it like the celebrities.
Yeah.
It could open up more opportunities for them by.
Well, I mean, yeah, that could be one way of looking at it, I suppose. And I'd like to think that they do and have their heart in the right place for doing it, but there is a possibility. But equally, one thing I would say, if you've got, not that I've mentioned there's a correlation completely between that and mental health, because we know it's multifaceted, but equally, you know, if you've got £100 million in the bank and you can access a lot of resources and you've got a big support network at your disposal, it's a lot different to a single parent trying to support kids and afraid to lose their job, who've got bills knocking on the door, and they face a high degree of external pressure as well. Does that sort of make sense? So I think that, you know, that's not undermining it, saying it's not multifaceted. It doesn't mean that, you know, you're wealthy, you can't suffer. Of course you can. You can suffer equally as much because we know that there's a lot of factors involved in it. But what I'm saying is that, you know, the general person probably doesn't have that luxury to be able to openly talk about things. And we want to get to a point in society where they can. I mean, and if anyone debates that, and the way I put that sort of argument to bed, my teaching fellow at that point, I said, well, you know what? You ask the general person in the street to call into work and say, I can't come in this week because I'm feeling depressed. What's your reaction going to be? Why don't you do a scientific quality survey and speak to people and say, well, you know what? I'm not feeling great. And I know it because I was working one time, to give you an example, with this gentleman at an organisation in corporate work, and I was doing some corporate training, and he was suffering with mental health, and they were trying to get some coaching for him. And I sat him down and I said, you know, talk to me, you know, as you do, because he'd had some coaches come in to see him prior than I went in. I said, how are things going? Because he was behaving erratically, and so on and so forth. And he said, I'm really struggling at the moment. His daughter had passed a few months earlier, and he was really struggling to come to terms with it. And I said, I don't think coaching's for you. I'm going to go back to the director with you, and I'm going to make a suggestion that you get the therapy you need, and I think that's probably the best way to do it. And I told the director I think he needs more time to help, and he turned around and said, how much time? Believe it or not, he said, how much time does he need? And I just, you know, bit my tongue at that point and just said, well, you know what, think about what you said, and you know, come back to me. But equally saying that we know now environment, genetic. So, you know, we know that genetic environment is correlation. You know, genes are at play, environment's at play. We don't know how hard someone's going to hit. And I think most people, I give most people the benefit of the doubt. I think most people would prefer to be functional and get up in the morning and feel okay. very small. I can't imagine a great deal of people would want to actually get up in the morning and feel like they've been, their whole family's been wiped out and that sort of stuff. It's a horrible feeling. It really is. Depression is a very serious condition that can't be made light of. People, and it has a correlation to suicide. And we don't know enough about it to make any judgment to say, well, it's because of this, that, and the other. We know it could be multifactorial. It could be inflammation, it could be, there's so many theories out there that are being explored, and until we have more affirmative biological indicators in diagnostic criteria, then one can't take these things, not that we could take them lightly then, but at least at that point, we can get to the point where, if you were to call into work and say, I've got diabetes, I've got to go in to see A&E, or, I've just twisted my knee in an accident, it'd be a different response to, someone suffering adversity saying, I'm just struggling to cope today. It's just too damn much. And we talked about, obviously, the economic implications, and it's not always as easy as that. So we've got to question the wider structure here, the bigger picture, So some of the research suggests risks. Well, obviously, the male risk, does not say females aren't at risk, but the percentage is higher amongst male, and there's a number of theories around that. The low socioeconomic status as well, restricted educational achievement, parental separation, divorce, parental death, adverse child experiences, parental mental health disorder, family history of suicidal behaviour, interpersonal difficulties, mental disorder, drug and alcohol misuse, helplessness. So these are all according to the research. That's not saying that that's exhaustive. It's not saying that you don't meet that criteria. People can't have a mental illness or suicide or self-harm. Of course they can. But if you read the literature, the highest risk probably points to these areas. And that's not including, obviously, the genetic risk that people can face with mental health too. So I'd like to think that family history can probably, So in saying that, in a way, there's a lot of things you can control, there's things that you can't control. So you can control some things you can't control. You're born in a world where, you don't control what genes you're given. You don't control the family you're born into. You don't control certain life events. So there's a lot of things that people don't choose, and they're in a set of circumstances. If someone's born into a world where they're abused early on in life, it's going to have an impact on them. It's like, for example, I wrote an article I've seen on LinkedIn about that gene, the warrior gene, so it's called, and a lot of people in offending institutions have got this sort of gene that's been identified. They're in aggressive behaviour, but equally, if the person doesn't have adverse experiences, the incidence of aggression and acting out is no more than the other person. But equally, if the person doesn't have that gene, if exposed to adversity, they don't generally go on to be aggressive. But equally, all things being said and done, if they both have adversity, the gene will be expressed in some people and prompt antisocial aggressive behaviour. So what I'm trying to get at there, when you sort of study, and also study like, identical twins, you'll see that, okay, one twin might get depression and one might not. So it shows that there are other things at play, not just genes as well. And I suppose, one time I was at a seminar and the guy was saying, well, in the same family, one person becomes a lawyer, one person becomes an offender, one person becomes one or the other, insinuating, one's reaction to events in certain situations. But equally in saying that, we know that our genes can be different in the same family, unless we're identical. But equally, the parents don't treat all the kids the same. So I didn't mean to be contentious, but I said, well, actually, if we're going to look at things a bit deeper and explain behaviour, not all parents treat the same children the same, by the way. Some siblings have a different role than other roles. So one sibling might become a terrible thing for other children. One might have been abused. So before we sort of make presumptions about one's mindset accordance to one going off and becoming one thing or the other. Let's look at the deeper picture. And not put extra pressure on people and make them think, well, actually you're a failure, you've done something wrong for feeling that way. Because a lot of the time, it's probably nothing to do with anything that you've chosen. And like, people don't choose to have cancer. People don't choose to have diabetes. They don't make a conscious choice to have that. Leukemia, you wouldn't say, you've chosen. People don't choose to be depressed. It's not a choice you make consciously in respect to the biological indicators going in the brain. Okay? And I strongly disagree with people who sort of make light of it and think, okay, it's a way of thinking, it's a way of being. Absolutely ridiculous notion. To think someone's going to get up in the morning and think, well, actually, you know what? Is it heck? I think anyone who suffers from that suffers in a big way. We need to sort of do a lot of work to help people and find ways to help people. But self-harm, about 10% of young people will self-harm by the time they finish school. That's according to Madge et al. Okay. If you want more information on some of these areas, do feel free to email me. I'm only covering what I can cover on this course. I'm not a clinical expert in these areas, but I have done dissertations on courses in great detail, and I've come across some interesting literature that makes, if nothing else, interesting reading, and one can help people based on our remit. Prediction is the problem. Even for the best clinicians and most studied clinicians, predictions when it comes to self-harm and suicide is one of the biggest challenges. There's a whole body of research to suggest that. I don't have the time to cover on this course or part of the course, but if you do get a chance to sort of read on that for a number of reasons, predicting. From the point of view of self-harming, I suppose in one sense it's almost like a positive immediate outcome. I'm not saying positive, not great or just harm, but it's like a pressure cooker. Now, when I used to deliver education in care homes, there was a high prevalence of self-harming in that environment. Some of the young people in that environment had grown up in unsecure attachment, if we sort of think Bowlby theory. And it's not to say if they're not in a secure attachment, they can't begin to feel safe. And I think there's been neuroimaging that showed evidence that in the brain structural changes. But cutting a long story short, the reactive attachment disorder that some people show, where they almost like give up on anybody being able to help them, particularly adults, and they end up in these sort of reciprocal roles. Reciprocal role being, for example, me here being teacher, you being learners, and we might go to lunch, and the reciprocal role might be friends or acquaintance, or equally you might go away and teach this evening, and reciprocal role. So you see all the young people in the self-harm, the reciprocal role for them is almost like abandonment, sadness, let down by the system. Okay, so then they develop the coping strategy. And sometimes they try to reciprocate in the sense that to take some control of what they can control. And they kind of push away, so to speak. But equally, whilst that might serve as a positive outcome because it relieves the pain, emotional pain, which the emotional pain we know now is linked to physical pain in the brain, but there's a long-term negative consequence, isn't it? Because then you experience more pain, not just physiologically, because the pain won't go away. So certainly in those situations, the young person or a person of any age who makes self-harm requires clinical help. And obviously, as we mentioned earlier before, we escalate the issue and get the necessary treatment for the person as quickly as possible in those situations. There are a number of apps as well. I can email you these slides as well too, that people can access to. I'll send them through to you, but there are a number of apps that can help support people with mood disorders, addiction, depression, and they're not a substitute, obviously, for clinical help and so on and so forth. And if someone has suffering, then it's always best to run it by the clinicians before they sort of access the app. But there are apps out there too that are accessible. Yes, I believe so. I believe that relates to mindfulness. Yeah.
Quite good.
Yeah, and so there's stuff out there that's useful. There's PTSD coach, there's post-traumatic stress, there's crime for schizophrenia, reducing isolation. There's LifeSum, there's Happify, Quit That, What's Up, sorry, and so on and so forth. So, you know, there is stuff out there people can access if they need be. We'll talk about the assessment after the lunch break as well for that. But I think that the common theme before we break for lunch is that we talked about the prior to our break about the escalating situation. So, you know, we've discussed in the course that signs to look out for the person could be at risk, and you know they included the withdrawal and anxiety and depression and loss of interest in things they enjoy. So, you know, someone who generally enjoys going to football on a Friday, they don't bother going no more. Or, for example, you know, if someone says they can't make a match, say you go on a Saturday as a one-off, you think, well, okay, but if it's continuously, and then they turn up looking like they're withdrawn, and they're sort of signs that we use for, not from a clinical point of view, from a point of view of talking to the person about getting help, you know, the way they communicate, and so on and so forth. And I think the thing is, really, the common theme is that, you know, all of us, you know, the statistics are high. All of us are going to, you know, at some point in our life, if not us directly, someone in our family will suffer if we go what the stats suggest, the 1 in 4. And I think it's really important, you know, to create some sort of awareness and hopefully the powers that be would increase resources and funding in this area, because we know it has a huge correlation to a number of things, behavioural, but also, you know, social context and so on and so forth. So I think whilst we've made strides and it's improving in my infinite wisdom, in my opinion, it's still a long way to go. And, you know, it's something that we all live life, I guess, on a knife edge, in the sense where everything could be going well for anybody in life and all things could be good in the world, but we know that life's very fragile. You know, anyone can suffer any adversity at any point, express a series of genes, and, you know, the classic case is a person who's successful for everything they ever wished for, literally overnight ends up living on the street. And it's easy to make a judgment on people and say, well, this, that, and the other, but equally, until you walk in someone else's shoes, it's best to reserve judgment, suspend reservation, just sort of get a bit more of an indicator and see. None of us are immune. And I like to think that, you know, in a society that one day it might be one person, somebody else, if we can sort of extend our arm and hand, and when someone else is suffering, do what we can, and equally that person will be there for us, or other people can extend the gratitude for us, as and when something does happen in that way. And that's how I think as a society will start to move forward. But equally saying that one's reading is important too. I think sometimes, you know, people mean well, but they're probably not the right person to help that person. And I think the course has been, you know, really useful in providing people detail to at least be able to say, you know what, you know, GP, as we've sort of mentioned before, in summary, to make the assessment that needs to be made and get the treatment that the person needs to be treated with, and so on and so forth. So on that note, we shall break for lunch, and after lunch we'll sort of go into some more practical exercises and sort of cover the components of other mental health conditions or disorders, how you're going to put it, and we'll talk about emergency aid in those areas, and we'll go from there. So is 1:30 okay for everybody to have lunch and do whatever you think? Thanks.
Thanks.
Thank you.